So have you ever felt like you're just treating a vocal cord rather than the actual person attached to it? Well, welcome speech-language pathologists to this explainer on the principles of voice therapy. Whether you're fresh out of your clinical rotations or a seasoned pro, today we're going to dive into some fantastic presentation material from Konyang University to really elevate this foundational knowledge straight into your everyday toolkit. Because as an SLP, your role is uniquely powerful. You're literally bridging the gap between medical anatomy and human expression. Okay, let's just dive right into it.
Here's our quick roadmap for today. We'll start with your core goals, move into direct versus indirect techniques, and then look at strategies to individualize care. After that, we'll hit prognosis, evidence-based practice, and finally, how to successfully discharge your patients.
All right, part 1, core and goals of voice therapy. Let's establish exactly what it is you do and the really profound goals you're aiming for in the clinic.
Think about how we typically frame our work. Voice therapy isn't passive, right? It's a highly active behavioral intervention. You're not just handing a patient a pamphlet and telling them to rest their voice. You're actively modifying years of ingrained vocal misuse, and you're fundamentally strengthening their biomechanics. Helping them acquire efficient vocalization techniques is what actually reduces that daily vocal fatigue. And brilliantly, this behavioral work often goes hand in hand with surgical treatments, like vocal fold injections or laryngeal microsurgery. You're stepping in there either pre-op or post-op to absolutely maximize the effects of those procedures. You ensure the physical fix actually sticks.
You know, as an SLP, you're way more than just a technician. You actually have this dynamic dual identity. First, you're the communicator, providing all that crucial knowledge on voice facilitation. But, actually, scratch that. Equally important, you are the facilitator. You're the one encouraging them to actually push through the hard work of behavioral change. And this whole dynamic relies on collaboration. Effective therapy requires a really tight partnership with ENT specialists. When you share case histories and analyze strobe exams together, you aren't guessing. You're building highly targeted goals that hit the root of the problem.
Ultimately, your goal goes way beyond just fixing anatomy. Yes, getting the best possible sound within their physical limits is key, but think about the real-world impact. It's the difference between a teacher who can simply make sound and a teacher who can project their passion to a busy classroom without the constant fear of losing their voice by lunchtime. You're restoring their ability to express true emotion so they can confidently navigate their social and professional worlds.
Okay, moving on to Section 2, direct and indirect therapy techniques. Let's open up that clinical toolkit. You absolutely must master the sharp distinction between direct and indirect therapy. Direct therapy means you're right there in the trenches, physically manipulating the mechanics of the voice. You're coordinating respiration, phonation, resonance. On the flip side, indirect therapy is all about managing the environment and the psychological triggers that sustain the disorder. This is your patient education, stress management, relaxation. And honestly, managing the environment is often the toughest part of the job because it requires total buy-in from the patient once they walk out your clinic doors.
Way back in 2000, Stimple categorized these tools into 5 approaches: vocal hygiene, symptomatic, psychogenic, holistic, and eclectic. So why do we lean so heavily on the eclectic approach today? Because blending methods, like mixing indirect vocal hygiene with direct symptomatic therapy, covers all your bases. It tackles both the mechanics and the environment. Research consistently shows this mix yields the highest effectiveness. It's also a great reminder that if there are underlying emotional issues, mechanical therapy alone is kind of going to fall flat. You have to manage the whole picture.
So, how do you deploy these? It's a very logical progression. You always start with a comprehensive assessment. Then, you move to trial therapies. Now, why is trial therapy so absolutely crucial? Because voice therapy is incredibly individualized. An exercise that works magic for one patient with nodules might completely rack the vocal cords of another. Trial therapy stops you from wasting weeks on the wrong path. Once you see how they respond, you pick the best format, whether that's structured, intensive, group, or even teletherapy.
Section 3, individualized strategies. Because all those brilliant methods mean nothing if they aren't perfectly tailored to the person sitting across from you.
When you've got a kid in your chair, you have to look at their physical development and cognitive ability. But the real secret sauce for pediatric voice therapy? It has to be fun. Age-appropriate reinforcement is key, and utilizing the parents is non-negotiable. Think of the parents as your at-home SLPs. If they aren't monitoring behavior outside the clinic, the amazing 45 minutes of work you just did can literally be undone by one screaming match on the playground the next day.
Now,
If you're facing a professional voice user, a singer, a broadcaster, the whole strategy shifts. Their voice is literally their livelihood. You might have to negotiate sick leave or adjust their schedules. And the pressure they are under, it's immense. So in these cases, you are part therapist, part mechanic. You have to provide deep psychological support alongside very simple, safe daily routines to manage their long-term vocal health.
And for our elderly patients, you have to walk a really fine line. You need to empathetically distinguish between the natural limits of aging and an actual treatable disease. You have to manage expectations without killing their hope. Plus, you've got to weigh their physical realities, like cardiovascular endurance, against psychological factors like loneliness. Ultimately, your goal here is maximizing their communication so they can keep participating socially and avoid isolation.
Let's jump to Section 4, Prognostic Factors and Evidence-Based Practice. Let's look at what actually guarantees success.
Success isn't random. It hinges on these 8 critical factors. Think of it in 2 buckets. On the patient side, do they even realize they have a problem? Are they ready to ditch their bad habits? Are their expectations realistic? And then on the clinical side, is the therapy suitable? What's the physical state of their vocal cords? And frankly, how competent are you as their SLP? All of these factors have to align for a good prognosis.
And speaking of your competency, that's where evidence-based practice, or EBP, comes in. You have to constantly integrate the latest research with your clinical skills and the patient's needs. Why? Because public awareness of voice therapy can be pretty low. People don't always get what we do. Grounding your work in solid data builds immense trust, which shoots their compliance and motivation right up. Plus, using EBP is your ethical duty. You are the sole qualified medical practitioner for this in the healthcare space.
And that brings us to our final section, successful termination of therapy. How do we know when it's time to say goodbye?
Boone gives us these 5 clear criteria for termination. Ideally, you discharge them when there are no more visual abnormalities or when you see objective, measurable improvement. It's also huge that the patient subjectively feels better. But let's be real for a second. Sometimes you hit a plateau, and you have to make the tough call that no further improvement is possible. Or, even more realistically, the patient just ghosts you and stops coming. Acknowledging all these scenarios prepares you for the realities of the clinic.
As we wrap up this explainer, I really want you to think about the lasting impact of your role. When you look at the very next patient who walks through your door, ask yourself, are you just restoring their physical voice, or are you restoring their confidence to communicate with the world? Keep that dual identity of communicator and facilitator alive. Thanks for joining me on this deep dive, and keep making a profound difference in your clinics.